Hi guys, good morning, good morning, good morning. Welcome to Saturday Clinicals with Ask Nurse Alice. Sorry we were delayed this morning with getting started, had some technical difficulties, but I didn't give up. I definitely didn't give up. Wanted to touch base with you guys this Saturday morning and get things going. So I just want to say welcome, welcome, welcome. Again, apologies for the tardiness, but we are here and we're about to get the show on the road. So for those of you who may not know and who didn't join us last week, my name is Nurse Alice. I am a cardiac clinical nurse specialist, family nurse practitioner, emergency room nurse with over 23 years of clinical experience as a nurse. I worked mostly in critical care, stepped down, worked in the emergency room, and I floated around like any other nurse, right? I'm also nursing faculty at Charles Street University here in Los Angeles. And teach pre-licensure in a pre-licensure accelerated nursing program. So I'm not new to teaching as well. I've been doing that for several years. And some of you may know me from Nurse.org's Instagram Live that I do every Tuesday, Beyond the Bedside with myself and Nurse Haskins, where we talk about a variety of nursing issues, topics, things that nurses should know about. We dive into polarizing topics and just get conversations going. And so one of the things that, I really enjoy that platform, but we noticed that we needed to give Facebook more love. And as well, there were definitely quite a few questions, clinical questions that people wanted to dive into that we weren't able to do on Beyond the Bedside. So this is that platform. This is Saturday Clinicals with Ask Nurse Alice, where I am your virtual preceptor, clinical instructor, really but not really kind of thing. And just to kind of help refresh people who also may not be in school, but just want a little oomph and in a fun way. So this is not class. This is not school. This is like just a little talk shop about important clinical issues, diving into deep things. If you're not in nursing school, and if you can think back about when you had kind of pre-conference, post-conference, or had lunch with your clinical instructor, and you just talk about what's going on with the patient and share examples and things like that. We are HIPAA compliant. I will not be talking about specific cases, but similar cases. And then just reviewing a little anatomy, physiology, bringing a little bit of that evidence-based research into the mix, but basically just have a casual conversation about clinical things that nursing students and nurses who are currently practicing should know of, be aware of, and might just need a little refresher on. So what I would want from you guys is, interact. I know you guys can't chat with me verbally, but if you have questions, comments, have examples, please put those in the chat box so we can make this a colorful conversation. Let's see what else. So be engaged. And then also Nurse.org and myself are really excited to bring this to you. So if this is something that you like, want more of, you want to hear about certain topics, you can contact them, leave your comments below. And then also if you want to get in contact with me, you can reach me on all my social media platforms at Ask Nurse Alice. And I kindly ask that you please go to my Facebook page, like that, follow me on Instagram and Ask Nurse Alice. And I also have a podcast called Ask Nurse Alice, and you can also watch the video version of it on YouTube. So if you could subscribe to my YouTube, that would be amazing as well. But I'm here to help you. I know what it's like to be in school. I know what it's like to be the clinical instructor. So my goal is to help you get through your clinicals, whether it's through school or your actual everyday work. So if y'all are ready to get the conversation going, we're going to get going. And please share this live with your friends, your classmates, your colleagues, your teachers, and all those things. I think this would be very helpful, and it will stay on the Facebook page when we're done. Okay, guys, and in addition, I want to say that it's also kind of brought to you by, in addition to Nurse.org, is Nurse Approved. So Nurse Approved, you can go to imnurseapproved.com website. Has some great products and goodies that we'll get into. Not going to get right at this very moment. We're going to get into the clinicals, but please make sure to follow nurseapproved.com and go to their website as well. I will write the website in the chat box too, so you can see that. Okay, so guys, if you joined us last week, you know that our initial conversation was kind of how to be the rapid response nurse without truly being the rapid response nurse. I know it can be a real scary experience when someone's deteriorating. You maybe initiated the rapid response team, or maybe you're not sure if you should call an RT. Kind of what can you do in the interim while all that's going down? So we talked about that. There was kind of an algorithm and an assessment process that we went through, and I kind of wanted to segue into that. I know we were promoting this, if we're going to talk about ABGs, and we are, but we're going to kind of segue to that using the kind of the respiratory system, our pulmonary system. So if you don't mind, I'm just going to go over some key components of the respiratory system, drop some gems and some tools that might be helpful to you in clinical, at school, or in your everyday practice, and just do a little refresh. Some of us, we don't want to do the full CV thing, but we want to hear a little something to kind of get our clinical skills jazzed up a little bit. So I'm going to go ahead and jump into that. So I'm going to pull this up. And guys, I just want to say I'm tardy because this whole trying to get my slides up was the issue. Last week we had a hard time with it. So let's do a quick review, right? You guys, please, sound off in the chat box. Let me know if you're a student, if you're a practicing nurse, what area you work in, what school you're from, and if you have anything to add to it, that'll make this even more fun. Okay, guys. So if you guys kind of remember, just quick review of anatomy, right? We have our lungs, our trachea, our bronchi, bronchioles, alveoli, and our air sac. So really, really important this kind of thought process, think through that. So whenever someone's having a respiratory issue, you got to think, where is the problem, right? Is it in the lungs? Is it in the trachea? Is it in the bronchial, alveoli, or air sacs? And if you can systematically think about that when you're going through patients having any issue respiratory-wise, that could be very helpful to you trying to problem solve what's going on. It could be something as simple as there's obstruction. Maybe they got a Oreo cookie stuff in their airway. Well, okay, maybe they got an Oreo cookie stuff in their trachea. That's something that we need to know about, right? And obviously remove that to make an airway cookie. Hey, Michelle, new grad, thanks for joining us. If you have any questions or comments, please drop them in the chat box. All right, Katrina, student. Okay, cool. All right, so we're going to get this going. So is it in the bronchi? Perhaps my ETT is too far down, and it's gone into the right mainstem bronchi. And so I'm missing that left side of ventilation going on. So you got to think, like, where could my problem be in this process? Bronchioles, maybe it's the alveoli, right? The air sac. Maybe, and there's you guys can see this here, this alveoli that I have up. Maybe that's where the problem is, right? Maybe it's full of fluid, maybe it's full of pus, maybe it's full of blood, maybe it's collapsed, right? So that's an important issue. Practicing nurse. Hey, Jennifer, cardiac specialty. Good, I'm a cardiac pulmonary specialist. We're here. And cardiac pulmonary go hand in hand. So guys, but let me break it down to the level where I've seen, as a clinical instructor and as a critical care advanced practice nurse, where I've seen the issues. A lot of times when our patients are deteriorating, and the problem's happening with our pulmonary gas exchange. So you guys can see, and you guys let me know if you guys can see these slides okay. There's a picture of an alveoli there. So we breathe in oxygen, we exhale carbon dioxide, right? Got it. Now, around every little alveoli, right, like this, and as you can see in the picture, there's capillary system, there's a vascular system, right? So as we breathe in, that oxygen is going to cross into our bloodstream. So we're going to get the oxygen in our blood. And then as we're exhaling, that CO2 that returns back to pass around the alveoli is going to go out through the alveoli and out as we exhale, right? So it's very important to understand that there is gas exchange, right? The CO2, the oxygen, you have this gas exchange. If it does not, if something's in the way, blood, pus, fluids, or my alveoli is collapsed, that's going to get in the way of gas exchange. And it's all about the gases. I got to get, as I'm breathing in, I got to get that oxygen into my blood and move it around. It's not enough to just put a non-rebreather mask on someone's face. Don't care about that. You can do that all day, right? But if that oxygen that the person's breathing in isn't getting into the bloodstream, if there's not that, the diffusion of gases doesn't matter. Or I'm exhaling, I'm having this CO2 buildup. Why am I having CO2 buildup? Because the CO2 is not able to escape, right? So if I have a whole bunch of atelectasis and, my alveoli is collapsed, there's not going to be good gas exchange. So this is key things to know, right? Okay, so let's go on to this next slide here. So definitions. Let's talk about some definitions. Okay. Ventilation. We use ventilation and people use the word ventilation and respiratory rate. Ventilation rate, respiratory rate, as if they're the same thing. And they're not. They're not. So, important, guys. All ventilation is the process of moving air in and out of your lungs. Don't care about gas exchange. Don't got nothing to do with gas exchange. Ventilation is just the movement of air in and out, in and out. It's the diffusion that we really, really care about. That's the process of the molecules of gas passing from higher to lower air concentrations. Remember I talked about we breathe in oxygen, gets into our blood. Perfect, that's diffusion. As we're getting ready to exhale, we have CO2 returning and we exhale it out. That's the diffusion. The diffusion and movement of gas is where they need to be. So you take ventilation, you take diffusion, and you have this wonderful thing called respiration. So you need both of those, guys, okay? So if you just think about, think of it, it's a ventilator, like ventilator machines. You say it helps you breathe. All it does is it moves air in and out of the lungs. It doesn't help you with gas exchange. You can be on a ventilator, lungs full of fluid, you can still be very, very, very sick and die, right? So it's all about not just ventilation, but diffusion. That's important. And the perfusion, I should say, the perfusion of gases to the body via the circulatory system. You breathe the air in and out, ventilation. Diffusion, gases cross the barrier, really need to pass. Perfusion, that oxygen-rich blood gets to perfuse and get to the organs where it's needed. That's what's really, really important. Okay, and we also have this thing called dead space ventilation. It's the area where there's ventilation, but there's no perfusion of gas exchange. So if you think of it, the trachea, there's no gas exchange happening in the trachea, guys. So when someone's breathing in and out, and perhaps you know what tidal volume is, the amount of air moving in and out, doesn't matter in the trachea. Who cares? Because there's no diffusion, there's no perfusion. So we call it dead space because air and oxygen are passing through there, but it's not helping with any diffusion or perfusion. And interpulmonary shunting. So maybe your alveoli has good perfusion, right? Like there's good blood flow going around that alveoli, like in our previous picture. But there's no ventilation. Patient's not breathing. There's no respiration. Respiration to 4. I can have good perfusion around the alveoli all day, but if they're only breathing at a rate of 4, not acceptable, not compatible with life. And I'll just say this: anytime someone's respirations are below 8, prepare to bag. Prepare to bag, guys. Okay? So cool. We're going to keep it moving. And some of this will go by pretty quickly because you guys know a lot of this stuff. You guys are students, practicing nurses, and we're really, this is kind of just laying the foundation so we can jump into it. Okay? So, pulmonary assessment, boom. You guys know how this works. Got to know how to assess those lungs, right? Lung sound. Are you listening to the front and are you listening to the back? If you want to put that stethoscope in 1 or 2 places, you've done yourself and your patient. You guys really got to listen to the front and really got to listen to the back. Okay, so don't be afraid to leave your patient come sit up, come roll inside, take a deep breath, all of those things. And what's their breathing looking like? How hard are they having to breathe? So first off, what's my respiratory rate at rest? Count for that full minute, guys, especially if you've never, ever, ever met this person. Promise. I know a lot of y'all do 50 seconds times 4 to get that respiratory rate for a minute, but if you've never met a patient, first time, initial assessment, I promise you want to listen and watch them for the full minute. Because there's such a thing called apnea. So you can't really, assume that whatever's happening in that 15 seconds is going to happen in that full minute. Okay? Guys, chime in if you have something to say, if you agree, disagree, have any other questions. But we're going to need to look at pulse ox, right? That's important. I actually have pulse ox. I do. So, but I literally, pulse ox is very important. See that? See my pulse ox. Color. Any, are they pale? Are they flushed? All those things are important. See my think I'm excited when my ladies. But there's my fact. Are they using accessory muscles? Like, are they like using all of their chest muscles? That can demonstrate that they're having some breathing. Breath odor. Now, I'm not talking just about how it feels with your breath, but I'm talking about, do you smell something sweet or urine-like odor? That might tell us a little something about, like, decay or sweet breath, something like that. Is there pain associated with their breathing? Rapid heartbeat. Is it shallow and even? Is there a pattern? Are they coughing? Is it productive cough? All of these things you'll want to look at. Their physical position. Like, are they tripoding? Are they having a hard time taking breaths in? And do they have a history of pulmonary disorder? And side note, let me say this, especially for my students who are on here. I know you're gonna get a report from the off-going nurse. I love y'all. I really. Some of y'all give some half reports, some half-butt reports. I'm not even gonna lie. And it's not on purpose, it's necessarily. It's just because you're going by what the other person told you, and then you're going by what happened to your day. If your patient's in the hospital for like 2 weeks, you gotta know what happened. You gotta go to that history and physical, guys. If anything, every time I first meet a patient, automatically, I don't care if they've been here 2 weeks, 3 weeks, I don't care if A1 top nurse giving me a report. I'm going to report, I'm gonna do my own individual assessment, but I promise you I'm going back to history and physical and looking back to see what kind of tests have been done. We all know patients can come in for one thing, and by the time you get them, it's something else. So we want to know if they have these type of histories. Some of the things that I'm looking for in my assessment, have they had these type of tests done? X-rays, CTs, MRIs, BQ perfusion scans. Like, these are all different types of tests that can give us some information about the patient's pulmonary system. Okay? There's some things you can see on an X-ray that you're not going to see on MRI, and CT, vice versa. There's also, BQ mismatch, or excuse me, BQ ventilation perfusion scan. Oftentimes we order these like a PE, but what's my ventilation compared to my quantity of blood flow? So looking at those things. Pulmonary function test, how much air can someone breathe in, and how much can they breathe out for, like, COPD patients. Bronchoscopy, they want to go into peak. Sleep studies, labs, sputum. That's important. Like, what's in their sputum? Sometimes gives an indication of what's going on, and if there's a lot of it, get in the way. HMH from the CDC. That's important to know. But I'll tell you this: what I always get is patients can look a little bit labored, and I'll say, "Oh my gosh, the SAT's fine." A SAT, we don't treat numbers, we treat patients, right? So when you're looking at my SAT, when you're looking at your patient's OT SAT, it gives you a percentage. So what this is telling you is approximation of 97% of my hemoglobin are saturated, my oxygen capacity. But provided I have a good and normal hemoglobin, not too bad. But how many of y'all have patients who have been blood transfusions, who are anemic, chronic kidney disease, have low HMH because of their long-term disease, and so they have low oxygen carrying capacity? I don't care if your oxygen saturation is 100, but if your HMH is super low, you still have decreased oxygen carrying capacity. Important to know that, guys. And then also, my soapbox is, don't tell me OT static, you're not going to tell me the respiratory rate. I need to know those two, and then I'm still going to ask you what's the HMH, because I need a full clinical picture of what my patients do, okay? And here we go. Continuous monitoring, SpO2. You can do it continuously, you can do it intermittently. And end-tidal CO2 is golden standard, the amount of CO2 that we breathe out. So remember, guys, when we talked about breathing in oxygen, the diffusion and perfusing to your organs, and all that good stuff, excellent. But how about that CO2? How do we measure that, right? When CO2 is being exhaled, is there an adequate amount of CO2 being exhaled? Not everyone has end-tidal CO2 monitoring, but if you do, that is golden standard, and that is actually an American Heart Association says it's gold standard as far as assessing the effectiveness of respirations. Okay, so that's for a whole other thing. I can go way deep into that rabbit hole, but we're not. I'm just going to try to get to ABGs, which, ta-da! We're getting here, guys. We're getting here. So let's see, who else has joined? Has anyone else joined in the conversation, guys? I know we have some new grads, we have students, we have some practicing nurses. Want to know who's in the chat? There's going to be a lot more that we're going to be going into because we're really about to dive into our ABGs now. Again, this isn't necessarily a lecture. It's going to be more of an activity, workout type of thing, something, just like you talk to clinical stuff, people pre and post this conversation. That's what this is. I really want to get to your questions because this is what it's about. I'm here to help you guys. I know this stuff, and I'm here to help refresh others and teach others who may not know, and just maybe a little help. So we're going to get to ABGs. Let me take a look at my list up to where I want to be. So why do we do ABGs, guys? Why do we do them, right? Well, they help give us some indications of our oxygenation status, our ventilation status, and our acid-base status, guys. So it's really important. Many times you'll see this, like if someone's on a ventilator, they're adjusting oxygen. Respiratory-wise, someone's not doing really well. You'll want to do this, and even still, even patients, you'll see your nephrology. You're like, why is nephro or the ABGs? Because the kidneys are responsible for, very responsible and have their hand tied into acid-base balance, right? The kidney holds on to hydrogen ions, bicarb. Kidneys are responsible for all of this excreting and elimination and holding on to electrolytes. So that plays a role. Okay, so don't be weirded out if your nephrologist orders it. You can always a pulmonologist. Hi, Michelle. Okay, good. I'm oncology, so I definitely see how low HMH has effect on sex. Absolutely. Okay, so here we go, ABG. So I have a list of normals here, right, in the blue box, and then I'm gonna get to the smaller box. So this is one of those tools. You're like, oh wow, I knew that, and I don't know. Maybe some of you will say you don't know that, you didn't know, but in critical care, it's something we look at a lot. So here are the normals, right? PaO2, pH 7.35, 7.45, CO2 35 to 45, your bicarb 22 to 26, your SaO2 greater than 95, and base excess. So I'll say this: when you're first learning ABGs, the most important components will be your pH, CO2, and bicarb, right? The PaO2, SaO2, and the base excess we will get into as well, but those three that I mentioned, I really want you to know. But for those of you who are like, you know what, I know some ABGs, I just needed a little refresher. Here's a little icing on your cake, okay? So when you're trying to calculate what someone's PaO2 should be, so like, and this is like on room air, guys, our normal PaO2 should be 80 to 100, right? Should be 80 to 100. Now, as we get older, we maybe 70, maybe 65 as we get older, right? But on room air. If someone is on oxygen, that's important. So I don't know if you guys can recall, but, and let me say this. Usually it's a respiratory therapist that draws the ABG. In some places, a registered nurse who has demonstrated their competency can draw an ABG. And sometimes you'll have your intensivists or your interns or your residents want to draw ABGs, and that's cool. But if you recall, when you do an ABG, some of the important things, it's not just getting that arterial stick, right, and getting that blood. You get that and you stick it on ice. But what else do they ask you for? They ask you for patient's temperature and the amount of oxygen the patient's on. And the reason why that's important is because that's going to play a role in interpreting this, because there's a thing called the oxygen dissociation curve. I'm not getting to that because that's really critical care. Maybe if you guys ever express an interest, I'll go over it. But sometimes if we're hyperthermic or we're hypothermic, sometimes those oxygen molecules like to hold on to the red blood cells and not drop off. And other times, the oxygen is just like dropping off those red blood cells. So it makes a difference, and that's why we need to know those things. But just for your information, if someone is getting oxygen, so FiO2, and you'll have to calculate your liters, 2 liters, 3 liters, 4 liters, and all that other stuff. I think 50%, let's see, 40%. There's a formula, so don't quote me. I didn't come to talk about this, but calculate how much FiO2 your patient is breathing in. And then based on that, normal PaO2 should be this. So remember, I said that the PaO2 on room air normal is 80 to 100. If someone's getting additional oxygen and they're healthy, their PaO2 should be higher. Okay, so just kind of put that in your parking lot, especially for nurses who are looking to build on some pre-existing ABG knowledge. But let's go further. And guys, I'm trying to keep this under an hour. Okay, last time we went over, and I started late today, so I want to keep people be mindful of people's time. Respiratory acid-base regulation. Okay, so our respiratory system is responsible for helping to maintain some of our acid-base regulation. So lungs play a very important role. Ventilation and diffusion are responsible for your PaCO2 levels, right? So your CO2, normal again, is 35 to 45. So if your CO2 is greater than 45, you're hypercapnic, too much CO2, higher levels of CO2 on board, and sometimes due to hyperventilation, right? If I'm breathing slowly, my body's not exhaling enough CO2, so it's retained, so the CO2 levels climb. So that's why I would be hypercapnic. Here's some other reasons why someone might be hypercapnic: respiratory depression, over-sedation, overdose, head injury, all of those things. Decreased ventilation could be from neuromuscular disease, where they're just not able to, they don't have the muscle strength of ALS, where they just can't move. Those chest muscles won't help them with their breathing. Someone who's severely altered. Now, hypocapnic, breathing really, really fast. I'm blowing off a lot of CO2, So if I'm blowing off a lot of CO2, my CO2 levels drop. They're less than 35, and that could be due to hyperventilation. Okay, guys? So here's some other reasons: hyperventilation, anxiety, fear, those types of things. Pain. You can also be, if you're hypovolemic, head injury, or mechanical ventilation. Those could be things that can cause someone to breathe off too much CO2. And you're like, why mechanical ventilation? Well, if your vent rate is set too high, if you have your vent set for someone to breathe at 28, or not that you would, right? Oh, I've never seen that. But they're breathing off too much that way. Okay, so this is how your respiratory system plays a role. And so, guys, maybe you're in ICU, maybe you're aspiring to go to ICU, but a lot of times we base our ventilator's respiratory rate off of our CO2, off the ventilation component. Okay. Now you're like, I know it might feel like, oh, Miss Alice, you're up here, but don't worry, we're going to bring it down here with some examples and work our way back up. But I just have to mention these things so you guys have a pretty good understanding of it, and then can ask your question. Metabolic acid-base regulation. So remember I said don't be weirded out if the nephro asks for ABGs, because the kidneys play a role. The kidneys help regulate the bicarb levels there in the blood. They serve as like a buffer system for our acid-base balance. So a normal, water. I need to drink some water. Hold on. Okay. Bicarb level is 22 to 26. That's the normal. So whenever you're, let's see where I'm going with that. So like your metabolic acidosis conditions that increase your bicarb levels, like DKA, renal failure, ingestion of acid, those type of things, those are things that can lower that level. So if it's lower than 22, okay, guys, you'd be in an acid, that's acidotic. Okay, conditions that can decrease bicarbonate, diarrhea, GI loss, body fluid, all of those things, anything that's going to make you poop it out. Those two can also lead to a decrease in your in the bicarbs of less than 22. Now, what about when my bicarb level is greater than 26, right? That goes along with alkalosis. And some conditions that can increase that are antacids and giving someone bicarb. Those are things that can increase that level greater than 26. And there's some conditions that can decrease it, like the loss of gastric juices. Someone who's vomiting a lot, maybe you have your NG suction up way too high. You guys got to keep track of that. right? Maybe it's on continuous and you meant to be intermittent, and you're picking out a lot of that. And then excess diuretics. Those are things that can lead to changing the bicarb level, increasing them, causing you to want to be more alkaline. So there you go. And I know ABG is kind of a foreign language, and this stuff can get kind of thick and we can get lost in the weeds of it. But I promise once we get to the application and we start practicing it, it'll be a lot easier. So when someone has an ABG done, what are some things you want to look at, right? You're going to see these values, but we don't treat numbers, we treat patients. But in order to treat this patient, I have to have somewhat of an understanding of what these numbers mean. So when you're looking at an ABG, you're going to look at these factors. What is the pH, CO2 bicarb, the PaO2, oxygen, and base excess. Now again, these latter two, I'm going to mention them, but if this is your first time, your new work to ABGs, the first two components are going to be what's most important. Okay, guys. So let's go and let's work on some examples. Let's see. So this is where we kind of get interactive. I'm going to put something up on the screen, and I want you guys to work with me on this to see. This is helpful. Let's work through the problems together to identify this. And then also, if you didn't know, Nurse.org has this amazing articles on how to interpret ABGs on their website. So after you finish watching this, make sure to go check that out and read that. And this and that can be really complementary to each other to help you feel more comfortable with ABGs. Okay? So let's go into our first example, guys. Here we go. Here we go. You guys join me. Don't be afraid, and don't be afraid to throw out an answer that. It's totally okay. But let's look at this. On someone's blood, or excuse me, they've done an arterial blood gas on someone. They're interpreting the information. They come back and say, Ms. Alice, here are the patient's ABG results. And you see this number, you're like, what does this mean, right? So let's do it. What does this mean, guys? So 7 point, I'm going to work this out with you guys. I have a blank sheet on it too. 7.35 is my pH. So we know again that 7.35 to 7.45 is a normal range. Should we say the pH is a normal range? Yes? Yes, it is. Okay, so the pH is normal. Very good. The CO2. We know again that a normal CO2 level is 35 to 45. Does our CO2 fall within normal range, 35 to 45? Yes, it does. So that is normal as well. Bicarb, 23 to 23.4. We know that a normal level is 22 to 26. So is that normal? Yep, that's normal. And base excess, I'm not necessarily going to go so much into base excess, other than to tell you that the base excess, some of its use is considered, I won't say controversial, but not necessarily sure if it really makes much of a difference. But if it's minus, it's a deficit. If it's plus, it's a positive. And it refers to how much base is present in the blood. So if I have a base excess of -1, excuse me, a base deficit of -1, respectively, it's just the amount of base that's present in the blood. So knowing that kind of in the back burner is kind of helpful in sometimes determining which treatment to implement. But we'll get to that later. And then we talked about the PaO2. We said a normal PaO2 is 60 to 100. So this one really isn't normal, but maybe they're an elderly person, right? I'm not quite sure what's going on with this scenario per se, but for the most part, this person has a normal ABG, okay? That's why some textbooks say PaO2 pushing our elderly can go to 60. So normal ABG for the most part. Keep an eye out on the PaO2 though. Don't know what's really going on just yet with that person. Okay, so good. So let me just write that here in the answer. So practice 1, ABG is a normal ABG, keep an eye on the PaO2 value. Okay, guys? All right. Let's do our next one. Let's see. Boom, boom, boom. Where's our next one? Our next one is here. So let's work that out. I'm going to work it out with you guys too. All right. Number 2. All right, what does it say? pH of 7.46. We know that a normal pH is 7.435 to 7.45. So it's a little bit out of the range, all right? So if your pH is above the range on that higher end, if it's higher than 7.35, that is alkaline. Okay, guys? Just as if it were below the 7.35, that would be more acidotic. And here's a hint, and I told my students in clinical this. Think of your ABG interpretation as having a first name and a last name, right? So if you think of it that way, your pH will provide you your last name, your surname. So pH is 7.46. So again, if it's below 7.35, that's the acidotic side. If it's greater than 7.45, it's on the alkaline side. So because this is above the 7.45, it's alkaline. So whatever this name of this ABG is going to be, the last name is going to be alkalosis. Okay, so just know that. So we're halfway through the problem. We know this is alkalosis. We're just going to look for the matching first name to go with it. Your CO2. Again, a normal CO2 is 35 to 45. 35 to 45. Nurse Alice, this is on the lower end, right? So with your CO2, if your CO2 is less than 35, it's on the side of alkalosis, okay? If it is greater than 45, that's where it's going to be acidic, right? So looking at your CO2, based on what I've said, it's out of the normal. The normal is 35 to 45. It's 34, so it is on the side of alkaline. So we're going to put that our CO2 is alkaline there, okay? So far, pH alkaline, CO2 alkaline. Let's look at this bicarb. We know that a normal bicarb is 22 to 26, right? 22 to 26. Is that bicarb normal? Yep. It's within normal range. Right now, I'm not. So as far as interpretation, we're not going to look at this. Look at the last two things right now. Let's look at those first three. So my pH was alkaline, my CO2 was alkaline, and my bicarb was normal. Remember I said that your pH is going to determine your last name. So it's alkaline. So which one matches it? And which one's out of whack? Your CO2, right? So we know that this is a respiratory alkalosis. Respiratory alkalosis. And let's go a little further, guys. Let's talk about this. So you guys may have heard compensated, uncompensated. What does that mean? Well, whenever you have an ABG with some abnormal values and you've made a determination of what it is, the way you know if something is compensated or partially compensated or uncompensated is by looking at the pH value. If my CO2 and bicarb and all that stuff is out of whack, right, because it's trying to balance, trying to get this, it's doing what it's got to do to make the pH normal, what you would look at is the pH. So is my pH within normal range? Nope, it's not. So I would say that this is an uncompensated respiratory alkalosis. Okay, guys. I know ABGs is kind of thick and kind of rough sometimes. So this is why I wanted to go through some exercises to go through it. And I'll just say this, your PaO2, no bueno, 43.8. You're definitely going to need to do something for this patient. Respiratory alkalosis. So this patient, remember when we talked about it a little bit earlier about what can lead to alkalosis. One of those things could be hyperventilation. So it might be this patient's breathing too fast. So let's do something to manage why they're breathing too fast. Maybe they're in pain. Let's give them some pain medication while also giving them some supplemental oxygen. So if we can slow down their breathing by controlling their pain, giving them some oxygen, they can take some more effective and deeper breaths, and hopefully that can correct some of this respiratory alkalosis that's going on. Okay? And I know it's so much harder when we have like a patient to go along with this, but for this, we just got to go through some examples. Let's go, I got like two more or so, and we'll be done. Okay, guys, let's do this other one, number 3. Okay. pH, 7.36. Is this normal, abnormal, guys? Is it within the range? Again, pH range is 7.35 to 7.45. So is it normal? It's within normal range. Okay, cool. It's in normal range. But that CO2, what is that CO2 doing? We know that a normal CO2 is 35 to 45. So if it's less than 35, it's alkaline. If it's greater than 45, it's acidic. So it's greater than 45. It's 75. So this is acid, acidosis, or at least for my CO2. A lot of CO2 on board, trying to add a lot of acids in there. Okay, bicarb, 40.6. We said a normal bicarb is 22 to 26, right? If the bicarb is low, it's on the acidic side. If the bicarb is higher than the 26, it's the alkaline side. So what do we got going on? It's greater than 26, so it's alkaline. That bicarb is alkaline. So, okay, and then again, I'm going to hold off on the other two. I got a normal pH, or yeah, my pH is in normal range, but my CO2 and my bicarb are out of whack. My CO2 is acidic, my bicarb is alkaline. What's happening, right? Well, I'm going to tell you what's happening. What's happening is these two are struggling. They're doing like a tug of war type of thing to bring that pH into normal range. And that's what our bodies do to maintain homeostasis. Our body is trying to maintain a normal pH that's adequate for life. So what's happening? Kidneys are working harder with managing the bicarb. My lungs, my breathing's probably all kinds of funky right now, trying to manage, help manage this pH. So this is a unique one, guys, where, remember when I said compensated, uncompensated, partially compensated? So because my CO2 and my bicarb are off, and I have a normal pH, this is compensated. It's definitely something that's compensated, right? So let's go ahead and slap that compensated there. Now, for compensated what? How do I interpret the rest, Ms. Alice, right? Well, we're going to look at the pH. Is the pH, even though it's in a normal range, is it more on the acidic side or is it more on the alkaline side, right? So if you chop right down the middle of our normal range would be a 7.40, right? That's the middle range. So it's on the lower end of the normal pH, which we know is acidic. So we're going to throw acidosis on there. And you know what? I'm literally working these problems out with you as I'm doing this. Okay, guys, this is how we do it. So I don't want you to think that I have the answers right in front of me and I'm cheating. I'm not. I'm literally with my pen and paper, like writing down everything and doing it along with you guys. So, okay. So the pH is more on the acidic side. Okay, boom, got it. But let's look at this. Remember I said that the pH will determine the last name? So if we're going to say that pH's last name is acid, which of my other two are acidic? My CO2 or my bicarb? Yep, you said it. I heard y'all say it. I think, you know, virtually. I'm hoping y'all said it. The CO2. The CO2 is high. It's elevated. So that goes along with acidosis. So we're going to call this a compensated respiratory acidosis. Okay, guys. So that's the interpretation of that one. So let me write that in. Oh, I didn't write number 2 in the book. That's okay. Practice number 2 is, what did I say? I said compensated respiratory acidosis. Now, mind you, I don't have other information about patient's temperature or what level of oxygen they're on. But if this, regardless, we know that a normal PaO2 is 80 to 100. So I'm still concerned, because I also don't know their age, is PaO2. Now let's just say that this person was on oxygen or something like that. Remember when on the previous slide, and you guys can go back and look at the live, there is a slide that says if you're on oxygen, what your PaO2 should be. So just because this person is, body's working really hard to compensate this respiratory acidosis, I'm gonna guess that the patient's having some breathing issues, and I would go ahead and label that with some hypoxemia. So if you wanted to really impress the intensivist, you could say, oh, it's a compensated respiratory acidosis with hypoxemia. And then we'll get to that later, though, because I know this was really just meant to kind of introduce and talk about it. And again, this is not a formal lecture. It's not meant to be like replace your ABG lecture at school. It's just meant to kind of talk about ABGs in a very informal way. And so, let's see. Did I write number 2 in there? Oh, sorry, that was practice number 3. Practice number 3 is compensated. Hold on, guys. Respiratory acidosis, and I'll put with hypoxemia. Hypoxemia. What did I say was number 2? I should put number 2 for the focus. Oops, where did we go? Let me go ahead and put number 2, and then we'll get to the next one. I just have 2 more, and I'll get to some of your questions. So number 2 was, we said, uncompensated respiratory, I can't spell, respiratory alkalosis. And I'm going to put with hypoxemia. Just hypoxemia as well. Okay, yes, so Nurse.org also does have a great guide on ABGs. So you guys, go to the website, read that. You're going to want to go back and watch this replay, and then just practice. You need to practice this. But what I really want to do is kind of get to some practice. So this conversation, again, like in clinicals, you'll have people who know something, some that don't know something. And as a clinical instructor, I kind of just bridge and have a conversation. So this is really meant to be kind of informal, but more of an application, okay? So let's go into this next one. And so I only have 5. So this one and one more, and then we'll be done. I'll be asking your questions. Okay, so 7.16. Remember, guys, a normal pH is 7.35 to 7.45, right? And I promise you, even as many years of experience that I have, I literally do this on all my papers. Oh, can you see? I literally will like see the value. I'll write next to it what is the normal value, and then I'll make my interpretation. So I know that this is on the side of acidosis because it's less than 7.35. So I'm gonna write acid next to my pH level. Boom. CO2 is 42. Again, normal CO2 is 35 to 45. So I'm going to say, okay, that's the normal range. I'm going to put an okay there. Bicarb is 15. We said a normal bicarb is 22 to 26. And guys, some of the reason why I do this, I literally will write this and I will say it out loud, because when you say something, read something, hear something, you use different parts of your brain to memorize something. So that's a study tip. If you want to study, read out loud. So not only are you reading it, you're saying it, and you're hearing yourself. And that's like going to tickle 3 parts of your brain to help you remember stuff. But 22 to 26. So this is out of range. It is low. So I know that this is on the acidic side. So I'm going to call my bicarb as acid. Okay. And right now we're going to just bypass the base excess because that's more critical care. We're going to get to that stuff later. But in case you guys ever want to work it out, you have it. Based on those 3 elements, what is going on with my patient? Remember, pH is the last name of your ABG. So this ABG's last name is going to be acid, acidosis, right? Because the pH is acid. All right. Now, if the last name is acid, which of the other elements also match acid? Let's see. CO2 is normal, but my bicarb is acid. So, and I know my bicarbs are reflective of my metabolic system. So I'm going to call this metabolic acidosis. Okay, guys? This is definitely a metabolic acidosis. Now, remember I said compensated, uncompensated, partially compensated? So we talked about what compensated was, right? When the CO2 and the bicarb are out of range, trying to get the pH normal range. So this is not compensated because my pH is not normal. There's partially compensated would be when the pH still isn't in normal range, but my CO2 and my bicarb are out of range, still trying. They're trying. You can see that they're working, but they haven't quite gotten my pH into a normal range. So I would call that partially compensated because I know it's trying. It's trying. Now, if something's going on, and so here, we're acidic, bicarb is low, CO2 ain't did nothing. The CO2 is just chilling in its normal range, hasn't done anything, and is like, hello, CO2, you want to help somebody out? Want to help sister out? Try to bring this pH back to normal? So, but because the CO2 is still within a normal range and hasn't done anything, we're going to call this an uncompensated metabolic acidosis because if it were partially compensated, you would see the CO2 come out of its normal range trying to help, but it ain't did jack. Okay, so we're going to call this uncompensated metabolic acidosis. Okay, so let me write that here in the chat box for people who are going to come watch it later. So number 4 is uncompensated metabolic acidosis. And my PO2, if this were an elderly patient, would I think that, oh, this PaO2 is tolerable? I might say that they're older, but because I'm so acidic, I'm going to assume that this patient is not doing well. That's 7.16 is really not compatible with life. So I'm going to go ahead. This person definitely needs to be on some additional oxygen because there's just not enough PaO2 going on there. And there's a lot going on with metabolic acidosis. Do you guys remember what are some, and I'll sometimes, you know what, it's okay to look back, guys. Sometimes I have to look back and remind myself too about, okay, metabolic acidosis. What am I doing to correct my metabolic acidosis? Let's go back and look. So metabolic acidosis, what am I doing? Ingestion of too many acids, bicarb, perhaps, let's see, conditions that decrease the acid. Oh, excuse me, sorry, that wasn't it. Conditions that decrease acid. Loss of gastric juices, could be a lot of things going on. So you definitely want to get to the underlying cause of what's going on, because this right here, this ABG, no bueno, this is not compatible with life, okay? So we gotta intervene. And guys, and just so you're like, oh my gosh, am I really supposed to know all this at the bedside? This can be challenging. This is almost like learning EKGs. It's like an additional interpretation. It's like learning a different language, if you will. You're learning ABG language. The most important part is that you learn how to interpret them. So just get a name down. Like if you can say what it is, then you can always work backwards to see what could be causing it. But you can't even get to what's causing it. You can't even get to what's fixing it if you don't know how to interpret it. So that's what today's talk was really mostly focused on. And it's a really heavy topic. I don't know, maybe it was too heavy for our second episode, but ABGs are important, especially when it comes to your respiratory status. And I say that because let's just think about it. pH is out of normal. Who do you think is going to kick in fast? Who's going to kick in first to work? Can your lungs kick in first and fast, or will your kidneys? Let me tell you this: the CO2, right? Your lungs your respiratory rate can change pretty quickly, just like that. Your metabolic system, sometimes it can take up to 24 hours for the metabolic system to respond and to make changes to help correct that pH. Okay, guys, so just some food for thought there. And let's see, I think, was that the last one that I had? Hold on, let's see. One last one, guys, okay? And then we're gonna be done. We'll wrap it up. Okay, here's one. Number 5. Where's my number 5 at? So I can write on it because you guys see me writing, right? This is how I do it. And guys, again, this is not meant to be formal CE instruction. This is just Nurse Alice just kind of coming to y'all on a Saturday to kind of help someone talk through ABG interpretation, because we've all been there, we've all struggled. And just reading it by yourself and going through it by yourself can be hard. So I'm just here to help. And if you guys have questions, I mean, please put them in the chat box. This is not an easy topic, okay? All right, but it's an important one. Practice number 5. Okay, ABGs. pH, you guys, is my pH normal? Normal pH is 7.35 to 7.45. So is it normal? Nope, it's out of whack. It's higher, it's on the high end. So what does that mean? If it's on the high end, it is alkalotic. So we're gonna put alkalosis, right? And hindsight, we know that pH is gonna determine the last name. So whatever this is, we know it's gonna be some form of alkalosis. CO2, you know that the normal CO2 is 35 to 45, right? 35, 45. My CO2, is this within normal range? Nope. Is it high or low? It's high. We know that CO2 above 45 is acid. So I'm gonna put acid next to my CO2. How about your bicarb? 48.2. We know that a normal bicarb, again, is 22 to 26. If it's on the low end, it is acid. Yep. If it's on the low end, it's acid. And then if it's on the high end, it is alkalotic. So this one is alkalotic, right? Bicarb is alkalotic because it's above 26. And so, again, we'll say the red 2 for a second, here. pH, alkalotic. Which of the other 2 elements, CO2 or bicarb, matches an alkalosis? That would be your bicarb. You know, our bicarb is reflective of our metabolic system, right? So we know that alkalosis is the last name. Since the bicarb is also alkalosis, we're going to go ahead and label that metabolic alkalosis. Okay? Metabolic alkalosis. Let's see. And there we go. Okay. Metabolic alkalosis. There we have it. What else? PaO2, 58.7. That's low. Patient definitely got some hypoxemia going on there. So number 5, guys, would be, let's throw it in, what? I never said number 4. Okay, that was number 4. Practice number 5 would be, what did we say? We said metabolic alkalosis. Metabolic alkalosis, and also some with hypoxemia. We know that a normal pH is supposed to be 80 to 100. If you're a little older with aging, sometimes we get 70, sometimes as low as 60-ish, but we don't know anything about this patient other than the numbers that are in front of us. So we're gonna leave that alone and just say there's I spelled hypoxemia wrong. Don't judge me. Hypoxemia. Okay, so that is practice number 5. Guys, I know. Like, this was kind of heavy on a Saturday morning. I know, it was. And as a clinical instructor, as a virtual preceptor, being a nurse ain't easy, right? And not everyone in your practice will get exposed to ABGs. However, as a nursing student, I know you're all going to run through your med-surg, advanced med-surg, and things like that. So it's still something very important that you need to learn along the way. And then once you're practicing as a nurse, especially if you're in the hospital, acute care, any inpatient area, this is something that's important to know. Is it something like, oh my gosh, no, I don't need to know ABGs. I don't do that. I don't interpret that. Okay, keep thinking that way, because what's going to happen is your patient's going to deteriorate. The physician's going to order ABGs. They're going to be waiting for you to call them back with the ABGs. And so you're going to get presented with ABGs, and you should know. I'm going to go ahead and say that you should know the gist of what you're reading, because you're calling to report numbers. There should be some type of urgency if you're getting some abnormal values, but also with just calling to report, whether to the physician or nurse practitioner, on what these values are, you should be able to anticipate some of the treatments to help fix your patient. Because if the provider doesn't give you adequate orders, who's at fault? A little bit of them, a little bit of you. I'm just gonna go ahead and say that. As nurses, we are responsible for a lot of stuff now. I know you'd be like, I don't want that responsibility. I know, but it comes with the territory. So if you are in an acute care area, you are taking care of a patient and a provider orders an ABG, you should at least be familiar with it. And sometimes you don't memorize everything, but you know where to go. You know where to look it up. So at least do that. At least if you get some ABGs, let's look it up. But having some of this kind of common knowledge, which is what we covered today, is really important in helping you to do critical thinking, so you can, one, identify something's wrong, and two, begin to anticipate what the plan of care should be for your patient. And if you know what that plan of care should be for your patient, you can then assess, like, well, have we done this, and this? Maybe you have, and then we got to take it to the next level. So it's important to know these things. And but this is one of those pieces of information where if you don't use it, you lose it. So if you've learned this and you're like, oh my God, I totally forgot, refresh yourselves. And I promise you, after you refresh yourself every so often, eventually it's going to stick. Eventually it's going to become common knowledge. So ABG, again, is really hard. Why do we do them? Most of the time we want to assess the ventilation and oxygenation status and also metabolic status of our patients. And we just can't see this. This requires arterial blood for us to do. So can anyone just draw an ABG? No. Usually it's a respiratory therapist or a nurse who's met the competencies for doing ABGs, and your physicians can do it. So guys, this was, I just wanted to go over ABGs. I know. You're like, see, and this is a time where clinical instructors, like, you don't like us. And that's okay. That's okay. Because you'll still love me in the end, because I'm going to push you. I'm going to gently push you out of love to learn things, study things, and look at things that you may not necessarily want to because they're challenging, they're different, they're new, but nevertheless, it's still going to make you a better nurse. So it's been kind of quiet in the chat box. I don't know. This might be one of those topics you're like, really don't want to go over this, but we did, because it's important. And especially in the areas that I work in, emergency room, ICU, and CCT, like, I have to know these things. Knowing these values will help me to anticipate, do I need bicarb? Do I need to change my respiratory rate on my ventilator? Like, maybe we're taking out too many gastric juices. Maybe I gotta slow down on that low intermittent suction. Oh, but damn, the nurse prior to me left it on continuous and we emptied out all the acids from the stomach. Or maybe it's because the patient has diarrhea and they're losing, acid that, or, base or acid that way. So those are important things to know. Especially if you're someone who's interested in going into the critical care umbrella, whether that's telemetry, progressive care, step down, intermediate unit, DOU, ICU, any of those areas, especially ER, knowing these is going to be important. Don't be that nurse who works in those areas. Don't be that nurse who works in those areas and not know ABGs, right? That's okay if you don't know them yet, but you're trying to learn them. That's one thing, but don't be that nurse like, I don't need to know this. Yes, you do, especially if you work in those areas. Let's see what else. Any other questions or comments or anything like that? A little tougher topic today, but that's okay. We're in this together. And that's what I'm here for. Some of you will probably, actually, as I'm seeing, are asking me, will ask me questions in my email and things like that. Don't be afraid to ask questions. Ask Nurse Alice. That's my social media handle. Again, thank you to Nurse.org for allowing me to have this platform to talk about it. Just something to help you guys out a little bit as you're entering back into nursing school. I know it's going to be tough. Things have been crazy with COVID-19, but we're going to be entering back into clinical areas. And because you don't have traditional clinicals, many don't yet, it's going to be important to have these conversations, to practice and be creative with our learning and our studying. Thank you to Nurse.org for the platform. Again, they have a wonderful article on ABGs. It's in the chat box there for interpretation. Feel free to go back and play and share this video. Again, a very informal presentation on ABGs, kind of quick down and dirty. And what else? Yeah, and if you'd be so kind, I would love it if you guys could also go to my Facebook page and social media at Ask Nurse Alice. I'll follow you back, and make sure to check out every Tuesday on Instagram Live. Myself and Nurse Haskins will be on the bedside. IG Live Tuesday, 6 p.m., 9 p.m. Eastern Standard Time. That's always fun. And then, we'll try this Saturday clinicals and see how y'all like it. See how it goes. Maybe there's a different topic you guys want to talk about. But if so, in future, we will still do this on Saturdays. And it is supposed to be 10 a.m. Pacific. Just had some technical difficulties this time trying to get these slides up, but we got it. And we'll try this on Saturday, see how it goes. And what else? And I do this because I care about y'all. I know what it's like to be a student. I'm a passionate clinical instructor, and I really strive to make learning easier. So it's all out of love. And if you want to show the love back, you can check me out also on my podcasts on Apple, Stitcher, Spotify, all those things. It's Ask Nurse Alice. Please subscribe, like, and follow, and all those good things. And you can check out the videos of those podcasts on my YouTube, youtube.com/Ask Nurse Alice. Check me out there. And then, guys, if there's nothing else, one other thing. I wanted to extend this offer out to you guys because I know you guys are all nursing students or aspiring to be nurses. You'll probably be going out to clinicals, things like that, in campus and classrooms. Also, in addition to, it's just been COVID season, right? And we're entering flu season. I wanted to share my Nurse Approved travel kit. So you guys check this out. I have a back to school special I'd like to extend to you guys. So if you go to I Am Nurse Approved, you can use the coupon code back to school. I'll give you 20% off. This is a cool travel kit. It's waterproof. It's very small. You can stick it in your backpack, leave one in your car, leave one in your office, in your locker, whatever you got at work. Just emergency kit. It has 2 KN95s, a bottle of hand sanitizer, 2 pairs of gloves, and 10 antiseptic wipes where you can kind of wipe off your counters. And it's like a travel kit. Maybe you need to travel, right? Maybe you're flying somewhere, you're getting on a train. You want to have something to be safe with. Get a Nurse Approved travel kit. And if not for yourself, for your family member, great gifts. It's too early for Christmas, but great stocking stuffer, birthday gift. And check it out. So that's at IamNurseApproved.com. You can use the coupon code back to school. You get 20% off. And guys, I think that's going to round everything off. Again, thank you, Nurse.org. I am Nurse Alice. Thank you for attending Saturday Clinicals with Nurse Alice here on Facebook Live. And guys, if you have any questions or comments, please share them with Nurse.org. They'd love to hear from you guys. And as well, if you want to reach out to me, follow me on social at Ask Nurse Alice. And you can email me at info@asknursealice.com. And until next time, guys, be safe. Bye now.